right, well, good afternoon. It's a great pleasure to be here. Just a disclosure, I'm on the scientific advisory board for a company called Crinetics. So I'm hoping today to cover with you one of my favorite topics, which is the importance of bone health. We'll go over the effects of cancer treatment on your bones, how to optimize your bone health through lifestyle with diet and exercise, and when necessary, we'll talk about the medications that are available to improve your bone strength. So it's a great privilege to be here today. Not only am I a physician who cares for patients with bone-related issues from treatment for cancer and a scientist who studies this in the lab, but like many of you in this room, I've also been through the journey of being treated for breast cancer. So having received wonderful care, it's my own great privilege to give back. Let me start with the take-home messages that I hope you'll remember at the end of this talk. Fractures due to osteoporosis are serious but preventable. Your own risk of fracture depends on many factors that we'll discuss. Cancer treatments themselves can cause bone loss. You heard a little bit from Dr. Goldman earlier about the effects of hormone and endocrine therapies. There are lifestyle changes that you can undertake, and usually they will slow but not completely reverse your bone loss. And finally, when used properly, osteoporosis medications are indeed safe and effective. Let's start with some definitions. What is osteoporosis? It means literally porous bone. So it's a decrease in bone mass that can occur for a number of reasons, resulting in increased skeletal fragility and likelihood of fracture. To put this in perspective, it's incredibly common. It's estimated that half of all women over the age of 50 and 20 to 25% of all men will experience a fracture due to osteoporosis in their lifetime. For women, compared to the lifetime risk of breast cancer, which is about 1 in 8, so that's a risk of 1 in 2. For men, the lifetime risk is more similar to their risk of developing prostate cancer. Some general facts about osteoporosis. There are about 5,500 fractures due to osteoporosis, not necessarily related to cancer therapy, every day in the US. That's 2 million fractures per year. It's a major health problem. There are about 10 million Americans affected by osteoporosis, 80% of whom are women. I mentioned that there are 2 million fractures a year, and the direct costs are many billions of dollars. On the right are sort of the typical, most common types of osteoporosis-related fractures. About a quarter happen in the spine, or vertebral fractures. Another 20% happen in the wrist. I trained in Boston, where in the winter a lot of women slip on the ice and fall on their wrist. And so that can be common. Hip fractures are perhaps the most devastating. They're only 14%, but many people never walk independently again. And there's a high risk of mortality in the first year. And then a few other types of fractures make up the remaining. The kinds of fractures that can happen from osteoporosis do change with age. So in the bottom right, wrist fractures are most common in women around the age of 50 to 60. I think that's because in those age groups, when somebody falls, they have the reflexes to put their hands out and break the fall. As you get older, you can see that the risk of hip fracture really rises markedly, especially after the age of 70. Other kinds of fractures can happen throughout life, including spine and shoulder fractures. Why am I here? Because osteoporosis is very common among individuals who have a history of breast and ovarian cancer. There are a number of reasons why these individuals can be at risk for bone loss. Chemotherapy itself can be toxic to the skeletons. Premature menopause sometimes happens in patients receiving chemotherapy. A big reason that we'll go into a little bit more, and as you heard a little earlier, is the endocrine therapy that we use for breast cancers that are responsive to hormones. And radiation therapy itself can have some impact on the bones. So on the right is showing in light gray the percentage of fractures at different sites among women who have had breast cancer compared to the reference sort of population. And you can see that at every site, the light gray bars are darker. So there is an increased risk of fractures among patients and survivors with cancer. So let's talk a little bit about endocrine therapy for breast cancer. You heard some earlier from Dr. Goldman. About 80% of breast cancers express receptors for estrogen and or progesterone. We have different sources of estrogens in the body. In premenopausal women, the ovaries are the predominant source. In postmenopausal women, you can still have some circulating estrogens that derive from androgens. Those are the male-like hormones that are converted. When we talk about endocrine therapies for breast cancer, we mean a couple of different approaches. One is selective estrogen receptor modulators like tamoxifen, relaxafen, or bezadoxafen. Very commonly now, many women are treated with aromatase inhibitors, anastrozole, exemestane, and letrozole. These block the conversion of androgens from the adrenal glands into circulating estrogens. For premenopausal women, the amounts of estrogens produced by the ovaries are too high to only use aromatase inhibitors. So in premenopausal women, often they require ovarian suppression. And this can be accomplished medically with GnRH agonists like goserelin and leuprolide. There are also anti-estrogen medications that right now are used more in the metastatic cancer space. So endocrine therapies do indeed increase your risk for bone loss. Shown on the left side in light green colors are the natural rates of bone loss that can occur just as a process of aging. So in the years right around menopause is the fastest rate of bone loss. You can lose about 2% per year. In women who are more than 5 years after menopause, that settles out at about 1% per year. And you can see that in women who are postmenopausal on aromatase inhibitor, that number is a little bit higher. It's about 1.8%. But the dark green bars on the right show you what happens for women who were premenopausal at the time of diagnosis, who had to be put on ovarian suppression so that they could then have aromatase inhibitor to truly block their estrogens. And this is a very dramatic, as high as I've seen 10, 15% bone loss in 1 year. What I tell my patients is the normal transition through menopause, that perimenopausal period, takes about 5 to 10 years. When a woman is diagnosed premenopausally with breast cancer and has to be put on ovarian suppression, it's a little bit as if you took that body and shoved it through menopause all within 1 year. So you can see 5 to 10 years worth of bone loss within that year. It's quite dramatic. And my job is to work with our oncology team to try to limit that damage. All right, so what are the risk factors for bone loss? Age is a big one. The older we get, the higher the risk of fractures. Having had a previous fracture, so that risk fracture I mentioned in women in their 50s, lots of women come to me and say, well, you don't understand how hard I fell. I was in New York City this weekend. It's all decked out for the holidays. You can go ice skating on Bryant Park. And I had skates that were not very comfortable, so I fell a lot. And I realized how hard it is that you actually fall when you slip on the ice. So I get that. But also, you're not supposed to have a fracture. So if you've had a fracture from slipping on the ice or on the curb, that's a sign that you might have some risk. Certain medications, glucocorticoids, also known as steroids, do cause very dramatic bone loss. A family history, especially if you've had a parent, a mother or father who has had a hip fracture, that raises your own risk of having osteoporosis-related fractures. We spend a lot of time in medicine telling patients that being overweight is a risk for various diseases. Osteoporosis is one of the rare exceptions. So in osteoporosis, being thin is a risk for fracture. Tobacco use, excessive alcohol intake, other inflammatory diseases like rheumatoid arthritis, and other conditions like secondary osteoporosis related to other disorders that raise the risk of bone loss. All right, so how do we screen for osteoporosis? The most common way in the United States is what we call a bone density scan, also known as a DEXA scan. That stands for dual energy absorptiometry. This is our lovely technician at Stanford Hospital and what a DEXA scan bed looks like. It's non-invasive. You lie on this bed. It takes about 10 minutes. And it gives you information at the spine and the hips. And it gives you information about how strong your bones are, how much mineral density there is relative to young 30-year-old men or women, depending on your own gender. And that's because as an adult, your peak bone mass is around age 30. And so from these results, we can calculate whether your bone density is in the normal range. We use something called T-scores. These are standard deviations. So a T-score down to -1 is normal. A T-score between -1 and -2.5 is osteopenia. That's the yellowish zone. And if your T-score is less than -2.5 or 2.5 standard deviations below a young adult female for most of you in the audience, then the World Health Organization defines that as osteoporosis. So a few other points. I mentioned that fracture risk depends not only on bone mineral density, but also age. So we have calculators that can help us estimate your risk of having a fracture in the next 10 years. And in the dotted line, the Professional Society guidelines suggest that if somebody's risk of hip fracture over the next 10 years is going to exceed 3%, that we should think about treatment, because hip fractures are so devastating that we want to have a low threshold. And what I've shown you here is that across the bottom of this diagram, you can see the bone density scores from -1 on the right down to -3.5, which is a pretty low bone density on the left. And what you can see is you cross that dotted line at different ages at different bone density scores. So a woman who is 65 in that kind of dark blue line will cross the -2.5, will cross the 3% risk at a T-score of -2.5. Because I have a specialty clinic, I see many women who are younger than 65. So if you're in your 50s, you might not cross that threshold until you have a T-score closer to -3. But the opposite is also true. If you look at the highest age group, those who are 80 years old, almost at any T-score, their risk of fracture merits treatment. So important to keep in mind that it's not only about bone mineral density, it's also about age. And as well, the number of risk factors that you have. So whether you've had a previous fracture, whether you have a parental fracture, whether you are a current smoker, are treated with glucocorticoids. And this just shows you that the more risk factors you have, the higher the risk you have of fracture. All right, so who should have a bone density scan or bone density test? The general recommendations for all adults are that women over the age of 65, men over the age of 70, maybe 75. Younger adults, those over 50, if they have significant clinical risk factors, some of the factors I showed before. Anybody who's had a low trauma fracture after the age of 50. So again, back to that ice skating example, if you had slipped on the ice or tripped over a curb, fallen and fractured your wrist, you should have a bone density scan because that is unusual. And anybody who has conditions or medications that are associated with bone loss. There are some cancer-specific recommendations. So all postmenopausal women undergoing endocrine therapies, premenopausal women who will be started on ovarian suppression with an aromatase inhibitor should have a bone density at baseline. And it's a little bit debatable whether premenopausal women who are being treated with tamoxifen should also be screened. Tamoxifen is not quite as harsh on the bones, but in premenopausal women, it can cause a slight degree of bone loss. So our practice is to go ahead and screen if it's available. All right, so let's talk first about what you all can do health and lifestyle-wise to keep your bones strong. These are the recommendations from the Surgeon General's report on bone health. The first is to get enough calcium and vitamin D. We'll talk about the details on the next slide. Be physically active. So exercise is wonderful for so many benefits, but particularly with respect to your bone health. Try to limit your risk of falls. So I used to tell my patients, don't fall until I realized nobody's ever trying to fall. So that's not useful guidance. What you can do is limit your risk. So, those lovely throw rugs that you have on the ground that are sliding around, you can buy tape and stick them to your hallways. Have a nightlight so that when you get up in the middle of the night to go to the bathroom, you're not stumbling in the dark. Wear shoes that are appropriate and not going to increase your risk of fall. Maintaining a healthy weight, not smoking, limiting alcohol use, and finally, letting your doctors know about medications or diseases that you have that might impact your bones. All right, how much calcium? So for anybody at risk of bone loss, that's postmenopausal women, women with other risk factors, the recommendations are in the range of 1,000 to 1,200 milligrams a day. Dairy products are a wonderful source of dietary calcium. I generally keep in mind that one serving of dairy is about 300 milligrams. So you can see a serving is a cup of milk, a cup of yogurt, 1 ounce of cheese. There are other sources listed here. There are web pages where you can look up the dietary amounts. I sometimes have patients who say, what about leafy green vegetables? I've heard they're a great source of calcium. You can see broccoli does have some, but you would have to eat a lot of green vegetables to get your dietary calcium. Many people don't get more than a serving or 2 of dairy products. If that's the case, you might consider calcium supplementation. And you want to just keep in mind that your body can only absorb about 500 milligrams at a time. So if you're going to take calcium supplements, it's very common. Just split them 500 in the morning, 500 later in the day. The only specific recommendation is that if you're on acid blocking medications, so H2 blockers or proton pump inhibitors, you can think about taking a form called calcium citrate that doesn't depend on the acid in your stomach to be absorbed. Otherwise, calcium carbonate is fine. That is Tums. And one thing I've learned is that generic Tums is much cheaper than generic calcium that is marketed to women. Go figure. So you can go look for the generic calcium. Vitamin D is also important. It helps your intestines to absorb calcium. So again, for most adults who are at risk for bone loss, the recommendations are in the range of 800 to 1,000 international units per day. I try to keep things simple for my patients, so I tell them 1,000 milligrams of calcium, 1,000 international units of vitamin D. You can't go wrong. Vitamin D supplements come in different forms. There's vitamin D2, that's a plant-based supplement. Particularly if you have D deficiency, your doctor might prescribe a higher dose version. This is ergocalciferol. Vitamin D3 is the one that's commonly sold for 1,000 units over the counter. This is the version that we produce in the skin when exposed to sunlight or animal diet based. All right, let's talk about activity. Dr. Goldman already mentioned 150 minutes a day are the recommendations for healthy lifestyle, or 75 minutes of vigorous activity. For your bones, it's important to have some strength or resistance training 2 to 3 times per week. This can be body weight, it can be free weights, it can be weight machines in the gym, it can be resistance bands. I love that our goodie bags include a hot pink resistance band with some exercises. That's a great way to get resistance training for your bones. Balance and flexibility are also important. It's thought that one of the reasons that as we get older, the risk of fracture increases is because the risk of falling increases. So things like stretching, yoga, those are also important. These are some recommendations from the Bone Health and Osteoporosis Foundation. You can find many other websites that will list recommended activities. All right, so this is a complicated diagram, but it just gives you an example of how your medical team is thinking about whether you might need medication. So we've talked about at the top the recommendations for screening bone density or DEXA scan, again, all postmenopausal women, premenopausal women who will be starting on ovarian suppression and aromatase inhibitor, possibly premenopausal women being started on tamoxifen. If your T-score is greater than -2, so that puts you in the osteopenia range or better, and on the left side of this diagram, if you don't have any other additional risk factors, then we suggest making sure that you have plenty of calcium, vitamin D, and exercise. And then we recommend repeating a bone density scan in 1 or 2 years. This is important especially for the premenopausal women who are starting on ovarian suppression. Because they are young, most premenopausal women have normal bone density at the start. But as I showed earlier, they are also the women at the greatest risk for a very dramatic decline in bone density. So in women who are in their 40s, for example, starting on ovarian suppression, they might well have normal bone density, but if you repeat a bone density scan after 1 year of endocrine therapy, they may have lost 10 or 15%. Fortunately, because they're starting from such a good level, that usually is not a very low T-score, but it is important to watch carefully. If you have a T-score better than -2, but you have multiple risk factors, including age over 65, your T-score is on the lower end of that range, you're a smoker, you're very thin, you've had a history of your own fragility fracture after the age of 50, you've had a parental hip fracture, or you are on glucocorticoids for more than 6 months, then the recommendation is to consider medications. Likewise, if your T-score is already lower than -2, this is a very common scenario because most women, about 60-some% of women diagnosed with breast cancer are already in their 60s at the age where osteoporosis is quite common. And so again, we think about then treatment. And in those individuals, we want to monitor bone density at least every 2 years to see what's happening with the treatment. All right, so I tell my patients they're really very simple-minded approaches to how we manage osteoporosis. So the amount of bone that you have in the body is basically a function of how much is being made. Those are the brick layers on the top side of this seesaw, opposed by how much bone is being broken down, akin to the little jackhammer fellows. So that balance between the formation and breakdown determines how much bone that we have. And therefore, we have two approaches to treating bone density. We can either prevent bone breakdown or we can promote bone formation. I'll start by saying that in patients with cancer, there is not sufficient safety data for what we call the anabolic agents, the medications that promote bone formation. And so I and most bone specialists will not favor these as our first line. In rare cases, with special discussion, I think that's something we can consider. But for the purpose of today's discussion, we're going to focus really on the medications that prevent bone breakdown. These are about 90 to 95% of the medications that we use, prescriptions that we write for osteoporosis in general anyway. And these include medications called the selective estrogen receptor modulators, bisphosphonates, denosumab. I'm really going to focus on these two classes because they are the most commonly studied and used for these scenarios. So this is a summary table. It has a lot of information. It's not really something that you need to learn or memorize, but just again to give you a little bit of background when you meet with your own medical team. So we really have three classes of medications. We have what are called the oral bisphosphonates. The most common is alendronate. You've probably seen on TV as Fosamax. I think Sally Fields was a proponent of that. Most of these are weekly tablets with the exception of Beniva, which is a monthly tablet. These medications have been around the longest, 30 to 40 years. They are safe and effective. A few cons: the oral pills can cause heartburn in some individuals. With this class of medications, you do have to be careful with kidney disease. And the reason that Beniva or ibandronate is not in bold is because it has not been shown to reduce all types of fractures in the way that the other medications have. Intravenous medications are available, particularly for those who have heartburn or maybe just like the convenience. So what we have here in the US is zoledronic acid, commonly called Reclast. It's very convenient. It's an intravenous infusion once a year. Again, we have to be careful with kidney function. Some people, about 1 in 4 who receive this infusion, will experience flu-like symptoms. They'll feel achy, tired, maybe a low-grade fever. It should pass within a few days and should get better with time. Finally, there's its own class, a medication called denosumab, also known as Prolia. This is a medication for osteoporosis that's given twice a year as a shot in the clinic. It very nicely increases bone density. It has the advantage that if you have any kidney disease, you can still use this medication safely. The one important thing to remember if you're on Prolia is that it cannot be stopped abruptly. So it does increase bone mineral density nicely, but the minute you stop, if you don't transition to something else, that bone will disappear very quickly. And so for that reason, most often I will use one of the first two categories. But these are all medications that have been well studied in women with early stage breast cancer. There's a little bit of evidence that, especially for the intravenous form for women who are postmenopausal, that there is what we call an adjuvant benefit for cancer patients with early stage breast cancer. That means a survival benefit above and beyond limiting bone damage. And so the American Society of Clinical Oncology suggests that this should be discussed. Of all the agents that are recommended, the only one we have available is intravenous zoledronic acid, again called Reclast. For this particular indication, this particular reason, increasing survival benefit, denosumab, which is Prolia or Xgeva, has not been recommended. All right, so for the last 20 years, I have done nothing but care for patients with osteoporosis in my clinic. I've heard it all, and I greatly respect people's opinions and their concerns. So you might share some of these, or you may have heard friends or relatives with similar concerns. I prefer natural remedies. I'm very sensitive. I've read that osteoporosis medications can be dangerous. I know somebody who took this medication and had an unpleasant side effect. So these are all very valid concerns, and most of what I do in my clinic is to spend time discussing these and counseling patients on the options. So I do want to point out that the benefits of these medications far, far, far outweigh the risks. So shown here in the red bars are the risks of having fractures for every 100,000 patient years. That means you took 10,000 women and watched them for 10 years. I'm sorry, the gray bars are the number of fractures you would expect at the spine, at the wrist, at the hip. If you look at the red bars, those are the number of fractures that would happen in a similar population except treated appropriately with these medications. So I think you can see there's a pretty significant lowering of those bars. It doesn't go to zero, but it very dramatically lowers the risk of fracture by somewhere in the range of 30 to 40%. On the right, you can see that some of the rare side effects that we worry about with these medications, including osteonecrosis of the jaw or atypical fractures, those are very, very rare compared to the numbers of fractures that can be seen. And importantly, as you can see for atypical fracture, they're not even detectable until patients have been treated with 10 or more years of these medications. So we no longer treat individuals for 10 years at a time. We treat for up to 3 to 5, and then we pause for a drug holiday. That seems to mitigate the risk of these, again, very rare side effects. And this was from a task force that was trying to point out that these side effects are so rare that your risk of being in a motor vehicle accident or the victim of a homicide are probably, certainly a motor vehicle accident would be much higher. I think another way to think about this is that now over 10,000 patient years, so again, 1,000 women followed for 10 years. In red are the number of fractures that would be prevented. And on the right are the number of cases of these rare diseases, disorders that you might see. And I think importantly, again, we don't treat for more than 3 to 5 years. So you can see that the number of adverse events would be very low. And so the take-home message for all of you is that in the right patient, the benefits of up to 5 years of therapy with these medications far, far, far outweighs the risk. All right, what else can you do to lower the risks associated with these medications? So I think this is good practice for anybody, but particularly for patients being treated for cancer and treated with these medications. You do want routine, regular dental care, have good oral hygiene. Again, I mentioned the idea of drug holidays. That just means pausing these medicines every 3 to 5 years. Let your providers know about these medications, especially if you're planning any dental procedures. I alluded to the fact that if you're on Prolia, Xgeva, those are the brand names for denosumab, you don't want to stop those abruptly. And it is important to point out that the risks are greater at higher doses. So we don't have time to get into it today, but these medications are also used at much higher doses for the management of bone metastases. And so that is something to be aware of, that at those doses, the risks can be higher. All right, and with that, I'm going to reiterate my take-home messages. I hope I've left time for questions. Fractures due to osteoporosis are serious but preventable. Your own risk of fracture depends on many factors. You're all here interested because cancer treatments do impact your rate of bone loss. Lifestyle changes, again, calcium, vitamin D, and exercise can slow but not reverse, usually, the amount of bone loss. And I hope I've persuaded you that when used properly, medications for the treatment of osteoporosis are indeed safe and effective. And with that, I think I'm going to stop, and I'm happy to take questions.
Could you speak about Evenity?
Yes, so Evenity is a newer medication. It is one of the class of bone-building medications. There is no safety data in cancer patients. So again, it falls under that class of bone-building medications that, for the large part, we don't yet recommend for patients with a history of breast cancer. Just waiting for the microphones.
Hi, I have a question about the statistic that you showed at the beginning of your presentation. The percent of loss of bone density during 1 year, is it for every year of endocrine therapy, or it's just for the first year of when you start your endocrine therapy?
That's a great question. So the bone loss is highest in the first probably 2 to 3 years of endocrine therapy. So those numbers are in the first year to 2. After that, it probably does slow down, but it will likely continue faster than the natural rate with age.
And second question, if you are lucky and have your period after you stop your endocrine therapy, do you gain again your bone loss?
I'm sorry, repeat that?
When you're on endocrine therapy, your ovary stops producing estrogen. Once you stop the endocrine therapy, and if you have the chance to get back your ovaries working and your body starts to produce estrogen, does this affect the bone loss? Does it stop it? Does it recover the bones?
Okay, you mean if your ovaries recover after endocrine therapy. So that will depend on a number of factors. Some women who receive chemotherapy, they go into premature menopause and the ovaries will not recover. Other women who are on ovarian suppression, if it's by medication, there are other ways to suppress the ovaries, including surgical removal and radiation. But if you are on medications to suppress your ovarian function and treatment, and you otherwise would not have gone through menopause, there's a chance that it can come back. And if your ovarian function came back, that would be predicted to have a beneficial effect on the bones. But it's very much individually dependent.
If you're metastatic on long-term chemotherapy, should you have DEXA scans more than every 2 years?
I think that's a great question. So the issue for women with metastatic breast cancer involving the bone is that the guidelines currently recommend treatment with far higher doses of these medications, as I alluded to. That's because the studies that were designed to limit the bone complications of metastases specifically to the skeleton, these studies were designed 30 years ago. The average survival at that time was much shorter than it is now. And so they only focused on the very short-term benefits of these medications. It's clear now that patients are fortunately surviving much longer. We heard earlier today somebody 15 years. And so that's a testament to the advances in oncology care. It means we also need to think about the long-term adverse events of these medications. So it's an area for which there's not yet enough data. But we do recommend bone density scans. Every 2 years is still probably fine. Your bones don't change that quickly.
So I have had 1 dose of Prolia, and now I have an issue with a tooth that, one of my 2 front teeth that is going to need to get pulled, and donor bone put in, and a post to prepare for an implant. And I don't think that will be allowed to heal by the time the next Prolia dose is due. So what happens if I delay, say, by a month or whatever?
Correct. So I think that if you've had only 1 or 2 doses of Prolia, again, these adverse events are exceedingly rare. And so having had 1 or 2 doses of Prolia, the risk is still very, very low. It is something to discuss with your dental provider, the surgeon, your whoever's prescribing the Prolia for you. I don't recommend delaying the Prolia for more than 4 weeks at the maximum.
Thank you.
Hi, I have two questions. One is, how effective really are taking vitamin C, calcium and vitamin D in preventing bone loss? And at what point does it become, what difference does it make whether you take it or not? And then the second question is weight training really effective in preventing bone loss?
Great question. So the benefits of calcium and vitamin D. So the mineral in the bone, the substance that makes our bone hard and strong, is calcium and phosphate. So calcium is tremendously important to the amount of strength in the bone. So I think some of the clinical trials over the last decades have reported that they don't have a huge benefit. I'm not sure if this is what you're getting to for calcium and vitamin D. But that's largely because the average population today has much more calcium and vitamin D in their diet. So decades ago, when they first started studying this, if you take individuals who have no calcium or vitamin D in their diet, taking the amounts recommended do indeed have a benefit to the skeleton. And then your second question was exercise? Right. So I tell my patients this is the opposite of, we send astronauts into space. I'm a little bit fascinated by space biology. We live near NASA Ames, so I visited them a few times. I learned that our astronauts, when they go to the International Space Station, spend 4 hours per day, every single day, doing high resistance exercise because astronauts lose so much bone when they are in microgravity. So I think of this as the opposite. There's some really fascinating studies. If you are a tennis player and you started playing tennis before puberty, before your growth plates fused, your dominant arm is about 10% higher in bone density than your non-dominant arm. So absolutely, exercise and weight resistance training have a very important impact on your bones. Yeah, so the question is about weighted vests. They're getting a lot of publicity right now and a lot of debate. So I think the sort of thinking about weighted vests, in my opinion, the most logical is that if it will get you out and exercising, then that seems like a good thing. And particularly the weighted vest itself probably has some benefit on the central spine and perhaps the legs. It is not a replacement for weight training. So when I'm talking about weight training, I am talking about whole body, upper, lower, all the major muscle groups. So a weighted vest is not a replacement for devoted weight training. However, if it makes you feel motivated to go out and walk, I think that's great. There's a little bit of concern that, as with anything, when people take it up, there might be a slightly higher rate of injury. So again, take it slow and be gentle. Thank you for that.
What are your thoughts about vitamin K and calcium?
Yeah, so that's a great question. I get asked a lot about vitamin K, and many of the calcium and vitamin D supplements come with vitamin K. So my answer is that there is some preclinical evidence that vitamin K is beneficial. I only recommend things that have reached the level of clinical, large randomized controlled trials recommended by the sort of expert consensus panels. So vitamin K is not quite there yet. I don't think there's much harm. So if your supplements contain vitamin K, I don't think there's a need to worry. However, vitamin K plays very important roles in your blood coagulation regulation, your ability to form blood clots. And that's something that you don't want to mess with. You don't want to clot too easily or not enough. So you certainly want to avoid too much vitamin K.
With these medications, what are some of the commonly, what side effects do you see the most of, and what remedies do you do? A lot of us are wary about things just because
Yes.
we've had a lot of treatments, we've had a lot of things that have impacted, specifically like GI. I'm really wary of anything that would impact that because it's already been impacted by so many treatments
Of course,
already.
100%. I very much take that into account. So with the oral bisphosphonates, that's like Fosamax, the weekly pill, by far and away the most common side effect is GI irritation. And that's actually not the medication, it's the pill itself. I tell patients it's a little bit like they packaged it in little sandpaper bags. And I don't know why, there must have been good reasons. But the pill itself is irritating when you swallow. In patients without cancer, it tends to only be a problem if they already have a predisposition to reflux or heartburn. For that reason, especially what you mentioned, which is that many patients who've been through cancer treatments have already been through many medications. They may have GI side effects from lots of other reasons. I tend not to recommend the oral. So my practice is generally just to recommend for somebody on endocrine therapy, I say we go right to intravenous. My preference is reclass, so once a year. And that's for two reasons. One is to avoid the GI irritation. The other is just we know that you got the medication then. If I send somebody home with a prescription once a week, they might take a few tablets and then for very good reasons stop. And then sometimes they tell me and sometimes they don't. And I find out a year later that they did not take it for the year and now they've lost some bone. So if we use intravenous medication, then we know that you got treatment for that year. You don't have to think about it. For some cancer patients who are on many other medications, they don't want one more pill to have to remember.
Or is it just, would it be the same?
So you're talking about specifically for bone health or bone metastases?
Well, in my case, both.
Both? Okay. So, bone metastases is, in metastatic cancer, bone is usually the most common site. So most individuals who have metastatic cancer have involvement of the skeleton. And for that, the management is usually the same medications, but historically at far higher doses, 10, 12 times the annual dose exposure. So the good news is that at that dose, your risk of bone loss is already treated, right? It's effectively being treated for osteoporosis and bone loss because those doses are higher than we would use for osteoporosis. What I now spend a lot of time sort of advocating to oncologists is that we now need to think about the other consequences, things like the osteonecrosis of the jaw, atypical fractures, that again are very, very rare, but if you're taking a dose that is 4 to 10 times higher, that risk will proportionately be higher. So at the moment, there are no studies to show us what to do, so then I tell my colleagues we have to rely on common sense. And so what I have started advocating for is treating for the first year or two at the recommended doses, monthly, every 3 months, depending on the medication. And then it's a very careful conversation with the individual, their care team, pointing out the risks and benefits of continuing at these doses. So the most common thing I recommend is then starting to stretch out the interval between dosing for something like Zometa or reclassed. But again, that becomes a very nuanced, shared decision-making conversation with the entire team.
Thank you.
At 65, a bone loss of 2.5% is very high?
Bone loss of 2.5%.
DEXA measured. Bone loss of minus 2.5%.
Right, so it depends on the site. So we typically do
Lower back.
in the lumbar spine. Okay, and it depends on the interval, right? So is it 2.5% over 2 years?
Over 8 years. After 5 years of, after 7 years of aromatase.
Okay, So if it's a cumulative 2.5%, that is not very high, right? So remember that the average rate is 1% per year. So over 7 years, again, on average, most people would lose 7%. So 2.5% would not be terribly high. Well, I think we've answered all the questions. Thank you all.